and we're ready to go live. And Amira, you can take it away.
Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. Today's session will be hosted by Dr. Qaadir for Pediatrics and Policy. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they will be addressed.
Hi, I'm Asra. I'm honored to introduce Dr. Arshia Qaadir. Dr. Arshia Qaadir is a general pediatrician in Northern Virginia outside DC. She has been in outpatient practice for 10 years, caring for a largely diverse patient population. She completed her undergraduate education at the University of Chicago and her medical school and residency training at Rush University Medical Center, also in Chicago. She's a board member of the American Academy of Pediatrics in Virginia and co-chairs the Child, Immigrant Health, and Government Affairs Committees. She will be transitioning into Children's Hospital this year, where she will be joining the INOVA Cares Clinic for Children, a community health clinic that cares for undeserved families. She's also beginning an MPH program with Johns Hopkins Bloomberg School of Public Health this summer through their distance learning platform. I would like to request Dr. Qaadir to start today's session.
Good morning. Thank you so much for having me. Let me just adjust a little bit here and then I'll screen share. Okay, are you guys able to see my presentation?
Yes, thank you.
Okay, perfect. All right, so good morning, everyone, and thank you for inviting me to speak today. I'm actually really excited to do this talk as I was putting it together because it's an interesting juncture point for me in sort of my career path. I'm sort of at this midpoint, and as Asra mentioned, I'm actually transitioning myself between having been in private practice for about 10 years into shifting into more of an academic center. And part of the reason that I had an interest in doing that was actually related a lot to my recent work in child health advocacy, which we'll talk a little bit more about today. So thank you so much again for inviting me. So yes, as you mentioned, basically in order to become a pediatrician, you have to go through 4 years of undergraduate college and then another 4 years of medical school and 3 years of pediatric residency. If you want to further subspecialize into cardiology or any number of subspecialties as a pediatrician, then you would add on another few years of fellowship training. And so I've been in purely general outpatient pediatrics for about 10 years since finishing residency. And there are actually a lot of different opportunities and options available for you in pediatrics within the outpatient setting. So there's actually not just one type of outpatient practice as well. So for example, I've always been in a private practice that's been in more of a underserved community setting. So I've had a very diverse patient panel, lots of different ethnicities and languages, and I really enjoyed that. Most of my patients have been underserved or Medicaid recipients. And I started in a practice in Chicago that was a very busy urban clinic. And then here in Northern Virginia, kind of about 15 minutes out of DC, I've been in more of a suburban practice, but it's still a very kind of multi-ethnic diverse group. So I really, really enjoyed that. But there are other types of ways that you can practice outpatient pediatrics. You could be part of something called an FQHC, or a federally qualified health center. And that's a federally funded community health clinic that is geared towards caring for underinsured or families that don't have insurance, for example. It's kind of like a safety net clinic, and those are often in underserved areas, maybe very urban areas or very rural areas. And then there are other types of outpatient practices that are more like corporate run. So for example, like Kaiser in certain parts of the country, they have many outpatient facilities. And then there are hospital-owned outpatient practices, group practices. And so there are different models of how you might want to practice pediatrics, even as a general pediatrician. And then of course there are academic centers where you'd be able to teach students and residents and so on. And so there are lots of options. So as I was putting this presentation together and thinking about advocacy, and I was sort of reflecting on my own career journey and path, you know, one of the things that I thought of sort of mentioning to you guys, and it's sort of a little bit of a segue, but also a little bit of a maybe a tangent for a few minutes, is to kind of just reflect on and think about at this stage, as you guys are thinking about entering into a career in medicine, you know, what does it mean to be an advocate for your patient? And that can actually come in a lot of different forms. You know, what I'm going to be focusing on today is primarily how I got involved in a lot of the sort of state legislative and policy work. But in reality, there are lots of different ways that you can be an advocate for your patient at different levels. And you know, one of the things that I wanted to kind of remind you guys of is that, you know, every single opportunity that you have when you're interacting with patients is a chance to be an advocate for them. And it can be a very, you know, on a very small scale, or it can be something, you know, much larger, but all of those are very important opportunities. And, you know, as I was thinking about my career path, and I was thinking about high school and then college and medical school and residency, whenever I think back on those points in my life, I also have this parallel sort of timeline of, you know, what was going on in my personal life. Then in each of those stages of my educational path, there was also some family member of ours that was either in the hospital or we were dealing with some major illness. And so the reason I mentioned that is because it also gave me, I think, an interesting opportunity to be able to see things on both sides of the doctor-patient relationship throughout my, you know, educational journey. And so, you know, there were times as a medical student, for example, where I'd see a patient, it would remind me of, you know, my own family member and, you know, recently what they had been through, for example. And then similarly, like later on when I was in residency, and then if, you know, when I was in the hospital with a family member and I would see that resident come in and I would know, like, you know, she's been, you know, working 30 hours, that she probably has 20 patients on her, you know, list that she has to cross cover tonight. And you have a bit of an understanding of what it's like to be on both sides. And I think that that's a really important thing to kind of keep in mind, to be able to understand, to be able to empathize a little bit with what somebody else is going through. And so, you know, just to take a few minutes to kind of sort of emphasize this to you guys, you know, when you come into the field of medicine, no matter what specialty you think about going into, I think everybody has this desire to be compassionate and to do good and all of that. But the reality is that it can get very busy. It can be very challenging at times. And so I think even for the best of us, sometimes it's important to kind of remember that little actions can actually go a long way. And so, you know, when I think back to like residency, for example, there are often times that, you know, not only are you really, really busy, but there are times where you have to kind of experience things that can be very difficult, right? You can see really difficult things in the ICU, for example, and a part of you has to steel yourself, right? You have to kind of get through the night. You have to just do it, you know, do the work. You can't really fall apart. But at the same time, you know, as you're going through all these experiences, you want to always remember that that's somebody's, you know, sister, somebody's brother, somebody's child, somebody's parent, and not to lose sight of that. So, and sometimes you can feel a little bit like, you know, oh my God, I have so much to do, I don't have time. But I think time is really important when you are able to even spare a few minutes to just kind of sit with a patient, to kind of listen and understand what their story is, what you know they have experienced and what they've gone through. I think we do a lot of this preceptorship, experiences for medical students. And I don't know how it is currently in a lot of the medical schools, where you're shadowing physicians and getting a sense of what it's a day in the life of the physician is like. And I've always wondered, what if in medical schools you had to, spend a day with a patient, and just see what that experience is like, sitting in the hospital with the, IVs beeping and waiting for a nurse and all of that. Because I think the reason I guess I'm emphasizing that is because as you go through your medical career journey, sometimes you can kind of lose sight of that, even the best of us, just because of the demands of the curriculum and kind of what you have to get through. But I think, when you think about what it means to be an advocate for your patients, what it means to be an excellent physician or clinician, I think that these are all things to kind of keep in mind. The other thing I would sort of mention is that, when you think about what defines being a really, good provider, of course, you want to have the best, education, and you want to be on top of things. You want to make the right diagnosis, and you want to have excellent clinical acumen and all of that. But even with that, even if you make all the right, diagnostic assessments, even if you give all the right treatments, it doesn't guarantee, that you're going to get the outcome that you want for that patient. It doesn't guarantee that that patient is going to respond necessarily to the treatment. And so what you do have control over is your relationship with that patient, right? And so I think that's just something very valuable, that every patient encounter is a chance to listen, to learn, to be compassionate. And that, even those small, short moments may actually make a big difference to a patient. And I'll just leave you with one memory that I have from residency on that, which was that we had this teenage girl who came frequently to the hospital to get admitted because she had HIV. And the really, really sad thing about her case was that she was actually born with HIV. So through vertical transmission, which means that she got it from her mother during pregnancy and delivery. So she was basically born with this terrible diagnosis, with this kind of, I felt kind of almost like a death sentence. There's no cure. She was just like 14, 15 years old when we would see her, and she would have to take these horrible course pills and constantly be admitted for these terrible infections because her immune system was down. And it was a really difficult life for her. And she lived in a really, really poor area of Chicago, and it was really rough. And I often felt when we would rotate on her, I would just feel very helpless. What can we even do? I know that she's not going to get cured, and this is just terrible. And you just feel this sort of helplessness. And then there were times when I would be on call, overnight, and she'd just be sitting in, lying in the room alone, kind of dark. So sometimes I would just go in there and sit for 10 minutes, the TV's on. She didn't talk much. It wasn't like we had some great connection or, relationship or anything like that. But I would try, just sit, give her some company. And then sometimes I would kind of wheel her down to the gift shop and she'd get some candy and come back up. And I remember thinking back then, and a lot of the other residents would try to do the same. And I remember thinking back then, I don't even know if this makes a difference. It's like, she doesn't really talk much. And, maybe I should just go review some other patient labs or something like that. I'm not sure if this matters. And then when I left the rotation and went on to some other, part of the residency program, I was told that she would ask, where did that resident go? And, I didn't know maybe if she was missing my company or if it was just she wanted a free ride to the gift shop. But when I look back on it now, I think that those were really important moments, even if it was just 5 minutes, 10 minutes that you gave, to give someone some company. And she didn't live very much longer. She passed away during our residency. But I do think that those moments matter. And sometimes you don't even have to say anything. You don't have to do anything. You just have to be present and listen. And when you do that, you can also understand better what their needs are, and being a patient advocate could be just even getting that extra, cup of water or patient needs some new, hospital socks or something. Like, these little things actually go a long way. I'm going to talk about bigger things, but I just wanted to kind of remind you, I think that that is a really, really important value to have for all of you, whatever field you go into. All right, enough with my soapbox. So how did I get involved in child health advocacy? So I think this sort of came to my interest a few years ago. I had been in practice for several years. And I think when you're in practice, for several years, a lot of things start to become repetitive, right? Like, you see a lot of the similar clinical cases, you kind of give a lot of the same counseling, and things kind of go on autopilot. And certainly you have your interesting cases and things like that, but there's a lot of things that you see recurrently. And I think the other thing is that you see some of the roadblocks, some of the challenges, and certain trends in your patients and your patient encounters also on a recurrent basis. And so I started noticing things where, you just start scratching your head and wondering, is there a better way to handle this, to manage this? And so, for example, one thing that I remember is that we have, in my particular patient demographic, a really high percentage of kids that are not only obese, but have really high levels of cholesterol at a very young age. Like, you have 10, 11-year-olds with hyperlipidemia, abnormal liver enzymes, a lot of them with fatty liver disease already. And every year we would be, rescreening them and getting the same lab results and telling them about diet and exercise and nutrition. And yet I would constantly, face this challenge of, like, for example, the kids would eat breakfast at school all the time. And I'd ask them, what are you eating for breakfast? And it was always cinnamon rolls, cinnamons, like toast crunch cereals, all these sugary things. Even though there have been a lot of efforts made to have healthier food choices in schools. For example, that, I was thinking, well, how can we change that, sort of what is being served to them at school? That's something beyond my control. That's a county issue, for example. And then there was a nutritionist office right next to our office, separate from us. And I really wanted to refer a lot of these patients to her because, she could do great nutritional counseling with them. She's much more experienced in this than I am and has the time. We as pediatricians don't actually have a lot of time built in for a lot of that nutritional counseling, though we do it. And it's not something we're traditionally reimbursed that much for. So although we do that, the fact that I had a nutritionist next door was something I really wanted to take advantage of. But insurance doesn't pay for that. And most of the patients that I would see are Medicaid recipients, and Medicaid won't cover for any nutritional services. And they could not afford to pay hundreds of dollars out of pocket, for weekly consults with her and so on. And so I just feel very frustrated, like, why can't we get some, funding or coverage for these nutritional services when she's right there, Then occasionally we would have kids come in that didn't have health insurance. And, I would be kind of surprised, like, why do you not have health insurance? I used to live in Chicago. I did all my training in Chicago, and there every child had access to health insurance. And when you don't have health insurance, as many of you know, I mean, even a simple CBC or basic labs can cost hundreds, of dollars. And so it's really, really difficult to care for them. And then also and I will talk a little bit more about this, we would see kids with anxiety, depression, things like that. And they would come to us and seeking help. And we, as pediatricians aren't that traditionally trained in caring for a lot of these issues. And yet it would take them months and months and months to get an appointment with a psychiatrist. And so again, I feel like my hands are tied, like, what can we do? So I basically wasn't sure, how to get involved in advocacy. And there are lots of different ways different people do. The opening that I ended up finding was actually through the American Academy of Pediatrics, also known as the AAP, which is basically our organization, I would say, for pediatricians. But unlike a lot of other organizations, I think, for example, on the adult side, where their specialty groups advocate a lot for policies that might benefit the physicians, for example, in pediatrics, the AAP primarily advocates for issues that relate to children and policies that will improve, the health and wellness of kids. And certainly there's some advocacy for the pediatricians as well, like, getting better reimbursement from Medicaid and things like that. But the vast majority of what the AAP does is actually geared towards children, which is really, really unique and really great. So I was familiar with the AAP like nationally, but I didn't really know how to get involved. So I literally just, one day sent an email in January to like legislative affairs or to advocacy or something at AAP. And I said, how do I get involved? I have different things that I feel like I want to work on, but I don't know who to talk to find out, how other people do things. And then she directed me to the state AAP chapter, which it's kind of funny when I say this now, I actually didn't even know really existed. And I emailed somebody there at the Virginia AAP, and they said, well, it's interesting you're emailing us today because in 2 weeks, we're all getting together at the state capitol to lobby on what they call White Coat Day. Why don't you come down? So I had no idea what that was, but we went down to Richmond, which is our state capital here. And I got there and, 7 in the morning, it's a room full of all these white coats, pediatricians from all over the state, residents. I don't know if there are medical students there, maybe, but definitely a lot of residents were there. And basically all of these pediatricians and residents from all over the state come together once a year to go down to Richmond and talk to our legislators about different bills and policies that are on the table that are related to children's health. And this happens in January, once a year. And so it was a really exciting experience for me just to see that whole world. It basically opened up a window into this whole, world of advocacy that I hadn't really been familiar with. And so that was sort of my first step in sort of getting in the door. And so the Virginia state legislature, basically they come together traditionally between January and March is when they're in session. And there are 140 members between the House and the Senate. And the length of the sessions kind of vary every other year. But basically, the reason we would all get together in January is because that's kind of the beginning of session. And hundreds of bills are introduced that are just related to children and health, actually. And so what do we do? So we basically go through an extensive list of these bills that have been introduced by different legislators, for example, with the help of a lobbyist that we have who's very savvy and, kind of knows who's who down in Richmond and can kind of help guide us on the politics of a lot of things. And we kind of basically go through it, we red tape it, redline it, and we see, what are bills that we want to support? What are bills that we may want to oppose that we don't think are in the best interest of children? And then there's some bills that we're kind of on the fence or in the middle, or we don't want to take a very strong stance one way or the other. And so we kind of go through all these bills and decide what do we want to sort of strongly advocate for and what do we want to stand against and so on. And so there have been a number of different legislative issues, and this is at the state level again, that we have gotten involved with. And I'm just going to focus on two big ones in my talk today. But there were a lot of different things that we've kind of gotten involved in over the years. The gun violence prevention laws was a big one 2 years ago. So in Virginia, this is a very conservative state historically. 2 years ago in the state elections, basically the House and Senate flipped from red to blue on a very, very slim margin, like just a few seats. But that shift in political power happened after, I think, more than a decade, a really, really long time, maybe even a couple decades. And that kind of gave an opening for a lot of gun violence prevention advocates, including pediatricians that had concerns about safety issues for kids, to really push forward a lot of progressive legislation on the laws. Virginia basically had very, very lax laws when it came to gun safety. And so a number of legislative accomplishments happened 2 years ago. And that was really exciting for us to see. I think there are a lot of, just to give you a context, even just a few years ago, as pediatricians, we tried to get a law passed that would basically incentivize people to have gun safes in their homes. So it was like you would get a tax credit if you bought a gun safe, so no penalties, nothing, just incentivizing people to store firearm safety. That was met with like across the board opposition just a few years ago. So you can kind of get a sense of how big of a deal it was when the political makeup shifted and things were actually able to move forward on that front. And then there were other things that we did, like we raised the minimum age requirement in order to sell tobacco or vaping products, cigarettes to minors. So basically we prohibited it from being sold to minors, and it had to be only after the age of 21 that you were permitted to purchase tobacco products. Other things that we worked on, Medicaid expansion was a few years ago. That basically is funding for expanding the eligibility for Medicaid, which opens that up to a lot of families that were otherwise unable to access health insurance. So that's a big deal. And a few other things I have noted here. Some things are actually just even small things that we work on. For example, I think a few years ago, we had a bill that would increase recess time in public schools. So, little things like that are also often on the table. And so there are a variety of issues that we have worked on. And so a lot of people ask, well, what exactly do you do as pediatricians? We're not technically lobbyists, but we do a number of things. So like I mentioned, we kind of go through the bills and see what we want to support. And we also testify. So, a number of pediatricians may sign up to speak on a particular bill that either they are supporting or opposing. And it used to be that you have to drive down to Richmond, wait and then give your 5-minute spiel. But now this year, actually, because of the pandemic, everything is virtual. So it's actually opened up a lot of opportunities for more pediatricians from anywhere to kind of virtually testify. And so that has been a lot of fun. And even this year, we got some residents involved with a little coaching to be able to testify and to just speak on your own experience. So, if it's related to a bill, for example, you can kind of talk about that, give some facts, and educate some of the legislators on the issues. We also do a lot of outreach. So as the Pediatric Society's AAP, we have a lot of members all over the state. And so when there are particular bills that are important that we feel like pediatricians should know about, we'll use our social media and we'll kind of send out these voter alerts to get people who are in certain districts and who are constituents of key legislators to make sure that they send emails or make phone calls or get involved. And those voices actually make a big, big difference, especially, when you are a constituent of a particular delegate or legislator, they really do listen to you. So we definitely do a lot of outreach. And then, of course, we also meet with legislators. We'll set up meetings around the time of the General Assembly, and sometimes there'll be smaller meetings, like just a few of us. And then traditionally during that white coat day that I referenced, we'd go and sort of spend the day meeting with like 3 or 4 different legislators, depending on what part of the state we're from. We kind of all divide up, and then we'll go and meet, 3, 4 legislators or their staffers, and we'll talk about maybe 3, 4 key issues or key bills that we, are supporting or advocating for. And I think the most important thing when we do that is the fact that as pediatricians or any, clinician in any form of advocacy, is that we're bringing our patients' stories to the table, right? So a lot of times these legislators, you think like, oh my God, they're like politicians. You might feel a little intimidated. They don't know a lot of what we see, and so you'd be surprised, even as a medical student, the things that you will see in your patient encounters and the stories that you'll have, those are all really, really valuable experiences, and really important for legislators to hear. And they really appreciate that. I think especially as physicians, I think we're, as a community, generally respected by lawmakers. And so they've always, been very, very happy to meet with us and to hear our stories, and especially to be able to speak for our patients, and for us to kind of tell the stories of the children and the kids that we see and what, they've experienced. We definitely, find that valuable. Definitely with the gun violence prevention, there were a lot of stories that we were able to share about, what did people see in the trauma unit, what, happened, when the gun was left unsafely stored. And those are important for the lawmakers to hear. So I'm going to talk about two things. The first is a mental health access program that we have advocated for successfully over the past few years. And the second is about some legislation around getting health coverage for undocumented migrant children. So the first is called the Virginia Mental Health Access Program. So basically, one of the big issues, as I mentioned to earlier, that we've faced as pediatricians is getting kids access to mental health services in a timely fashion. And this isn't unique to Virginia. A lot of states, a lot of places deal with the same issues. And in Virginia, though, we're actually pretty far behind a lot of other states. So we were like number 47 out of 50 states in terms of ranking the ability of our ease of access to behavioral health services for kids when we're referring them out. So we're really, really far behind. And to give you kind of a context, more than half of our counties in Virginia even lacked one mental health provider or child psychiatrist or therapist. And so there are a lot of kids, especially in these rural areas, that just don't have access, and you'll wait months and months to see a mental health provider. And meanwhile, the statistics of, anxiety, depression, mental health disorders in kids are increasing. 1 in 5 children has at least some sort of a mental health diagnosis. And over the last 10 years or so, we've just seen a general increase to almost kind of like epidemic level nationwide, where ER visits are increasing. The ERs did a study over, I think, the past decade where they saw more than 60% increase in visits for mental health concerns. And the issue is that, as I mentioned before, they come to us, the pediatrician. Okay, my kid is dealing with this, and he's all these symptoms of depression, he doesn't leave, or really bad anxiety, and we'll basically just say, okay, we'll refer you to a therapist, we'll refer you to a psychiatrist, and we don't really manage that. That's how we've traditionally handled it, because most of us weren't really trained in that. And so our hands are kind of tied, but then meanwhile, these families really suffer because they can't get in. And so unless your child is actively suicidal, God forbid, or something like that, you can't go to the ER either. You're just kind of stuck in limbo. So, for example, I had this one teenage kid before, we got involved in this mental health access program, and he came in for, he was having shortness of breath, palpitations. I think he also had asthma. He used inhalers. And so parents were convinced that this was, related to, his asthma or something. So we were working on inhalers, and we did cardiac workup and just make sure everything's okay. And he really didn't really improve that much, because then he would come back a few months later, the same issues. And so when he came back 2-3 times, I was like, I would talk to the parents. I was like, you also have to consider, could this be something separate, and then you kind of delve a little bit deeper, like what's been going on. They had been refugees from Afghanistan, and this boy actually had a lot of sort of panic attack symptoms previously as well in certain contexts. And so when I kind of delved into a little bit further, it seemed pretty evident that a lot of his symptomatology was actually probably more related to an anxiety disorder. And so then there you are, where you're kind of seeing this as a diagnosis. And in a situation like that, where it's becoming quite debilitating actually for him, unable to go to school and things like that, there are medications that could be helpful in addition to therapy to just kind of like get everything under control. And yet, again, as a pediatrician, kind of feel a little bit uncomfortable. Well, I don't really prescribe those types of medications, et cetera, et cetera. So you're still kind of stuck, you know. So basically, the AAP, along with many other stakeholders, came up with the idea of something called the Virginia Mental Health Access Program. And this is not something totally new, because a number of other states have also implemented similar programs. And so the way it was designed for in Virginia is basically that there would be 4 components to this program that would allow for primary care physicians, so like myself as a general pediatrician or maybe a family practitioner, to get training and also resources to be able to care for these kids in their own offices. So for example, one aspect of the program is to do these seminars and training programs where they teach us about anxiety, depression, a little bit more about ADHD than we're traditionally trained in, and a lot more about the medications that could be indicated or used. Also about how to screen effectively for a lot of these conditions, what questions to ask, and things like that. A second component is that basically they developed a psychiatric consult line between the general physician and a psychiatrist somewhere else in the state, kind of like a hotline. So when you have a patient in your clinic that you don't know what to do about, or maybe they're on some medication, you're not too familiar with it, and you basically need to ask a psychiatrist, the idea is that the physician could then just pick up the phone, call this hotline, and get like an immediate call back and kind of run the case with them, and then, you know, manage that patient in their office rather than waiting 3 months to get an official consult. A third component of the program is to develop telehealth, which is actually interesting because this is before even the pandemic and everybody's shifting to telehealth, but to be able to reach a lot of those rural areas to provide telepsychiatry services. And the final component is something called care navigation. So care navigation is basically kind of like a care coordinator, but someone that could be able to help you refer those patients to therapists and services outside of just child psychiatry, for example, counseling and different things like that that are important in your specific region. And so this would be in different regions of the state. There'll be different regional care navigators that can help the patients find the therapists and services that they need that can often be very challenging. So these are the 4 components of this program. And so what did we do? So basically, back in 2018, we got a coalition of support, and that's really important in advocacy work also, is, you know, you may have a great idea, but it's really important to get partners involved. And so this was a public and private partnership. So there were, you know, Virginia Department of Health was involved, but there were lots of private insurance companies, hospitals were involved, and they basically all supported the idea of this program and the need to fund it so that it could actually get implemented. And so what did we do? We went down to Richmond and we lobbied. This is one of our delegates, who's a really nice guy, Delegate Keem. And we talked to them about the statistics. We talked to them about what we're seeing. We talked to them about how we as pediatricians need the support to be able to care for these kids and why this program would be so important and needs funding. And so back in 2018, we were successfully able to get funding initially through a federal grant called a HRSA grant, which was a good almost $500,000 a year for 5 years. And that really helped to kind of kickstart the program's implementation and rollout. But then, like I mentioned, we really wanted to get some state funding. And so that's where we got involved in lobbying and talking to our lawmakers about the program. And so in 2019, we were successfully able to get them to agree to allocate $1.2 million in the state budget for this program, which is really exciting and allowed us to roll out part of those 4 components in certain parts of the state. And then last year in 2020, we were ready to kind of, increase our ask a little bit to 4.2 million. Just to expand the program further into all parts of the state. And also at this point now you have some data to show what you did in the first year to kind of prove your case a little bit more. And so we were excited about that. And in January, we actually in 2020 did get that $4.2 million approved. And then by March, what happened? The pandemic arrived. And so the pandemic arrived and that changed everything, right? So the global pandemic comes, it just created this huge budgetary crisis everywhere, right? And at all the state levels, all of the resources obviously were redirected towards the immediate emergency needs. And so one of the things that happened as a result of that was the $4.2 million was basically withheld, if you will. And so we were concerned about that because at the same time as the pandemic was unfolding, we were also seeing more and more of these kids coming in with anxiety, depression. And so, even though it didn't seem like something that would be an emergent need, for us as pediatricians, we felt that this was still something very important, something that needed to be not put on the side, And so what did we do? We wanted to raise public awareness and bring this to the attention of the lawmakers, even in the middle of a pandemic. One of the ways that you can help raise awareness is through writing, through media, right? And through sort of getting involved in the news media at different levels. And so writing an op-ed, for example, is one really effective way to get patient stories out there and to kind of raise awareness of what's at stake. And so that's exactly what we did. We had been seeing, even just by the summer of last year, kids coming in, maybe 25% of pediatricians' patient panels were kids coming in for depression or anxiety. There were some preliminary studies showing increased suicidal risks, screens, and in different emergency departments. We were seeing kids suffering from a lot of loneliness, obviously, without going to in-person school, but also a lot of trauma and grief in the middle of the pandemic. There's a lot of death, a lot of loss, a lot of scary things happening. And also keep in mind that the schools traditionally have also been a source for a lot of kids to get counseling. So that was all shut down, right? Where kids would normally go to see their school counselors, that's no longer happening. So it really was taking a significant toll on children. And you guys may have heard about the concept of toxic stress and ACEs, but basically there are a number of things, including a death of a parent or very traumatic experiences that can be life-altering for children. And those are called adverse childhood events. And those stressors, those psychological stressors, over a period of time can actually lead to physiological consequences too. So there have been numerous studies that have shown how, repeated psychological trauma, stress can actually lead to heart disease, to diabetes, to asthma, to shorter lifespans as adults. So these are things that will have lifelong consequences. So we basically talked a lot about that in our op-ed. And then we sent it to every single legislator that we knew to tell them that, look, this is still something that needs to be on the table. We need to be able to ensure that we can still care for these kids and address their mental health needs. And there was an interesting Washington Post article I remember reading over the summer that framed it nicely, which was, and they were talking about not just children, but generally the idea that in any sort of natural disaster or public health crisis, like a pandemic, the way they described it is that after that, that disaster, after that pandemic, there's always a shadow pandemic that comes afterwards in the wake of that, which is the mental health, basically epidemic that then turns into a crisis. Because of all of the trauma, because of all the PTSD that people go through, and that we have to be prepared for. So we put together our talking points. We went back to lobbying. This time it was virtual, and we really kind of raised awareness of this issue. And we were actually quite successful. While we didn't get the 4.2 million, which would have been like I think actually a ridiculous ask in the middle of a budgetary crisis. We did get 2 million allocated for 1 year and then the full 4.2 million for the second year, which was actually pretty amazing in light of everything going on with the pandemic and the financial impact that it was taking. So again, this is just to show what can happen as a result of bringing these issues to the table, keeping the awareness and urgency of issues in lawmakers' minds. And this was definitely something that was not on their minds until we kind of really emphasized the need. I may skip over this a little bit just for the interest of time, but this is basically showing us getting trained and sort of the benefits of the program. But yeah, I was going to share a couple patient stories with you, but maybe I'll save that for later if people are interested. But basically, the really nice thing about the VMAP program for me personally was that it was something where I was able to see, you know, an endeavor that started as an idea, you know, something that we advocated for, get funded, become a program, start to get implemented, and then actually have direct clinical impact in my own practice. Because, you know, within a year, I was able to start picking up the phone and calling that hotline. And I used it. You know, I had a number of patients where before I would not know what to do. I would kind of just have my hands, you know, tied. And now I'm able to, if I need to call a psychiatrist, get some advice. I had a patient that was on a certain medication for depression. It wasn't working. And the mom just wanted to increase dose. I didn't feel comfortable, but now because I had some training, I knew what was an alternative medication I could start. How could I do that? How could I wean them off one medication, put them on another medication, and basically begin the process of helping them in real time rather than waiting. And it really, really has helped a lot of patients in our practice. The second thing I wanted to mention to you guys about is health coverage for children. So interestingly, not all children actually have access to health coverage everywhere. Traditionally, there's a program called CHIP, which is Children's Health Insurance Program, which is basically a federally funded program for states that allows for kids that may not qualify for Medicaid, but also cannot afford to pay for private insurance. They fall in sort of this gap. It's sort of a safety net health coverage program. Oftentimes it's on a sliding scale based on your income, your eligibility, but it basically ensures that children can get the health coverage they need and not go without health insurance. So, you know, most kids get covered. A lot of kids, a good 6 million or more, get covered that way that are especially low income. But when it comes to children, for example, that are undocumented, and that can be for a variety of reasons, but as you all have been seeing in the news, there are a lot of these migrant kids that are coming over for a variety of reasons. Only 6 states, including the District of Columbia, actually have health coverage options available for them. And these, as you can see, are a lot of these more liberal progressive states. But elsewhere, including Virginia, if these kids come here, they cannot access Medicaid, they cannot access CHIP services. And so they're left without health insurance. Why are these kids coming here? I mean, there's, again, a lot of different reasons that a child may not have access to health insurance, and a lot of different reasons that there might be undocumented families here. But one of the, you know, central issues surrounding what's going on now at the border relates to recent years of increased violence, gang violence, instability, and particularly increased levels of homicide on teenagers and children in Central America. So these are like what they call the Northern Triangle: El Salvador, Honduras, Guatemala. And in Virginia, actually, we have a very, very sizable population of these immigrant families from the Northern Triangle. El Salvador in particular has been noted for extreme levels of violence. I remember going to a conference a few years ago in which there was actually statistics shown at the time that showed El Salvador's level of violence per whatever metric they were looking at that point exceeded that of Afghanistan. And when you look at it in terms of how it's affecting children, this is just from a few years ago, but there are reports of, children in El Salvador that are 10 times more likely to be killed than a child in the United States in terms of the level of gang violence and homicide. So they are fleeing immediate danger and extreme levels of violence that I think it's hard for a lot of us here to understand. And often that is a reason why they are coming to the border. In regards to the crisis at the border, you guys may have been following this in the news. I was reading recently, I think just in the span of a month, there were more than 11,000 children apprehended at the border. And a lot of these kids are referred to as unaccompanied minors. Another term is unaccompanied alien children. That's the legal term. It's also, the acronym is UAC. So you may see that. But basically, when they come to the border, the federal law is that when they are apprehended in CBP custody, they're not supposed to be detained as children for more than 72 hours. After that, they're supposed to be basically sent to one of a few hundred different what are called ORR facilities, Office of Refugee and Resettlement facilities. So there are a couple hundred of them throughout the United States where these kids get sent, these unaccompanied minors, and they're kind of like shelters. Some are better than others, but they stay there, they get medical services there, they're housed there, residential facilities, and they're often there for anywhere between 30 to 40 days on average, before then hopefully getting reunited with a family member or relative. But what's happening is that these kids are getting detained at the border longer than 72 hours. And that's where you're seeing these images of the crowded, conditions down there and the concerns that everybody is having. Recently, Biden requested for pediatricians and other medical providers to actually come down. And so I think that there's some efforts to having some medical oversight and help. But it's sort of a lot of red tape. But I think our president of the AAP is going, or if she has not gone already this month. So this is just a graphic to give you a sense of, the alarming number of children that are being apprehended and detained at the border. And you can just kind of look at that for a second to get an idea of what that is looking like right now. But definitely, more than 18,000 kids, have been apprehended at the border. The other interesting thing just to mention that is part of the reason why there is this crisis of unaccompanied children is that there are a variety of reasons that kids may come across alone, but another factor is that a lot of these kids are coming with, say, a grandparent, for example. But the grandparent is not technically considered the legal guardian. And so even though they're there with what would appear to be a guardian, they're being separated at that point, right? So the child is allowed to stay, but then that grandparent is sent back, or that guardian is sent back. And so then they become unaccompanied at that juncture. And so that's also part of why we're seeing increasing numbers of these unaccompanied minors. So in Virginia, we actually do have a sizable number of these kids coming here. Since 2014, more than 18,000 unaccompanied children came and got resettled in Virginia. In 2019 alone, 4,000 UAC children came. And some of these numbers may be updated now. This is from, about a year ago. And again, so I talked about the Office of Refugee Resettlement. There's one main one here in Virginia, actually, which I'll talk about in a second. But more importantly to what our concern was in regards to health coverage, we have about 13,000 immigrant children in Virginia that lack any form of health coverage. And of those, 9,000 would fall under the federal poverty guidelines, in which they would otherwise qualify for something like CHIP or Medicaid, but because of their documentation status, they have no health insurance. So what can we do? I mean, everybody talks about like, how can we go down to the border? How can we help? But the reality is that at the state level, there is a lot that you could do locally, because we also have to be ready to receive these children when they come, right? And so one of the things that we did, and this was actually a few years ago when this was first becoming news, was we contacted the Office of Refugee and Resettlement facility here in Virginia, which is about an hour west of DC. And we said, hey, we're pediatricians from the AAP. We would like to come meet with you and see how we can work together to help these kids. And so we did. We went down, and it was actually a very good meeting. It's actually a pretty big facility. They do a lot of good services. And we asked them, how can we help? What is it that you see a need for these migrant children that you are transitioning? And the number one thing that they said that they needed help with was transitioning of medical care. So while these kids are in these ORR facilities, which is under the Department of Health and Human Resources, so they're still in federal custody in a way. While they're at these facilities, they get health coverage. They have some medical evaluations, they get some basic care, they get some screenings done. If they need to go see a doctor, those things can kind of be facilitated under the umbrella of HHR. Once they leave the facility and they are reunited with a relative or a family member, and it may be in another state, all of that is gone. They're on their own. And there isn't really any coordinated effort or means of getting them the resources of where they could go. And so what we decided to do in Virginia is at least start with pooling our own resources. So where could these kids go in Virginia if they needed health coverage? Where are the free health clinics? Where are the FQHCs? Where are the community health clinics? And so what we did was basically divide our state into 5 different regions. And we have pediatricians in each of those different regions that know their local area well. And so we basically just pooled our resources together. I said, I know Northern Virginia, I know these couple of clinics here. How about in Southern, or Southwest Virginia? Where do you guys send kids that don't have health insurance? And we just kind of collaborated, and it's such a simple thing, but we put it together, we pulled it into one sort of document, put it on our website, and then we shared it with the ORR facility, and then the ORR facility then shared it with, a lot of their colleagues that work at the border. And so we're hopeful that this will at least be a bridge to allow these kids to start to get to seek some medical care when they come here. Long-term goals. So all of us sort of kind of wonder in the back of our minds, could we actually change the laws in Virginia and get health coverage for these undocumented kids? Is that something that could happen? These types of long-term goals, again, in a very conservative state like Virginia, for example, are things you have to think of in sort of a 5-year game plan. And as I mentioned, we had some political shift in recent years. And so we actually really wanted to take advantage of that this year. But again, the pandemic. You have a pandemic, nobody wants to spend money on anything, the least of which would be on trying to get health coverage for undocumented kids. Nobody wants to spend that kind of money, right? But at the same time, we're seeing this crisis at the border. We're seeing increasing numbers of these kids coming in. And so we, again, what did we want to do? We wanted to raise awareness about this issue. So we did. We worked with some partnering organizations here in Washington, DC that collect data on basically a lot of health policy institutes that study migration and trends. And we got a lot of good data and numbers from them. We put that together in what we called a policy statement that we had the AAP sort of spearhead. We got partners. So we reached out to all the hospitals across the state, a lot of different advocacy organizations, legal aid organizations that care for migrant kids. And we got a pretty good coalition together to support our proposal. And what did we ask for? So basically, we knew we couldn't ask for funding. So we asked for the legislature to consider creating a task force or a work group that would start to study this issue, start to look at the impact lack of health coverage is having on these kids. Also look at the financial impact of the burden that this is having on hospital systems where these kids aren't covered, but maybe they come in for emergencies at the medical into the ER, And all of that cost has to be absorbed somewhere, right? Look at the financial costs, look at the medical costs, look at the impact that this is having on these kids, and then try to find some solutions. So looking at other models and other states where they have allocated funds for health coverage, see, what can we do in Virginia in the future to get these kids some form of health coverage? And so we started our, op-ed campaign again, raising awareness, shared patient stories. There were in the op-ed that we wrote, we talked about two girls at an FQHC that were undocumented and they both had epilepsy, and they ran out of their seizure medications. And as many of you could imagine, those types of medications cost thousands of dollars a month, and they had no way of obtaining those medications. And so, as physicians, we're the ones then trying to figure out how can we care for these kids? How can we get them, the medical care that they need, the subspecialty care that they need, the medicines that they need, and trying to pull strings and trying to find ways to help them. There was also I think it was a 2 or 3 year old girl, also seen at the FQHC, that had been apprehended at the border with her grandmother. Grandmother was sent back, and this 3-year-old girl was sent to an ORR facility in New York and spent a couple months there by herself before then she came to Virginia, and then we're seeing her, in our pediatric offices here. And she terribly needed dental care, right? So I think sometimes it's really important to humanize the statistics of these people and to put it into context, and so we definitely shared those stories with our legislators and lawmakers this year. And this was over the summer, actually, that we did this. And we were very, very excited that it was actually a budget amendment. Legislation went through both the House and the Senate, and it became an official thing. And so this is our budget amendment of, trying to remember when this was exactly, but basically effective July, the state of Virginia will, for the first time, create this work group or task force under the Department of Health and Human Services that will study this issue and try to find some solutions. And so right now they're building the partnerships and who will be on this task force. But it's pretty exciting because this issue of getting health coverage for undocumented kids has never even come to the lawmakers' attention, really, in Virginia. And so we had this window, we wanted to kind of get something done, and we were really, really excited to have some progress there. And lastly, just to close out these advocacy experience, I just want to mention that there are also things, obviously, that one can do at the federal level. Most of my work has been at the state level, as I mentioned, but the AAP nationally, once a year, also has this really fantastic federal advocacy conference, which those of you, once you're in training, and if you're interested in pediatrics, I would highly encourage you to attend. It's in April, and similar to what I described as our white coat date down in Richmond, basically hundreds of pediatricians come to the nation's capital once a year. And there's one particular issue that's usually a focus issue that we bring to the attention of lawmakers, and whoever your legislator is, you get to meet with them. And it's pretty exciting. So what we in the past had focused on for a couple of years was the issue of gun violence prevention. And in particular, this might be of interest to you guys, is that there was an amendment called the Dickey Amendment back in the late 90s that blocked any sort of funding for gun violence research to be done by the CDC. And literally what that law said was that none of the funds made available for injury prevention at the CDC may be used to advocate or promote for gun control. This was a total NRA lobby that was in effect for a good 20 years. And the reason that it was significant was that any public health issue, take tobacco and smoking, for example, unless you can actually classify it as a public health crisis through data, through studying the statistics, through studying the impact on health. Unless you can do that, you can't really, again, bring any of that data to the table when you're trying to change laws, right? So one of the things that I would also mention, and you may have noticed with our experience at the state level with advocacy, is that data is really important. Like, clinical stories are important, sharing the experiences of your patients, but also bringing some data and facts is really important. And so this basically blocked the CDC from doing that for 2 decades. And so what we did was basically really worked on lobbying for lawmakers to change that, to lift that sort of ban on research by the CDC. And this took a number of years, but ultimately in 2018, that restriction was lifted, and it was pretty exciting. And by 2020, fiscal year 2020, $25 million were allocated by the federal government to the CDC and the NIH to begin research on gun violence and firearm injury. And so that was something that was a pretty big deal, pretty unprecedented previously, but is again moving things in the right direction to understand the impact of gun violence on everyone, and in particular for us, on kids. This was, when we went down to DC, we got to hear from Senator Tim Kaine and meet with him, and that was pretty exciting. So just to close, just to remind you that there are lots of different ways to be a patient advocate. There's a lot of different ways to get involved in advocacy. My path and my journey was primarily through collaboration with other pediatricians, and in particular finding the American Academy of Pediatrics as an organization in which I could get involved and find partners and do things together. But everyone does it in a different way. There are providers that do things on their own individually at the community level where they are in their practice in their county. And again, like I was mentioning to you before, every patient encounter that you have is a chance to be an advocate, even in a small way. And so listen to your patients, learn from your patients. You'll be surprised about how much you can learn about life and broaden your own experiences and understanding by just taking a few moments to listen to your patients. And that can also help you to be a better advocate as you understand, as you empathize with what they're going through. So, and lastly, yes, advocacy also takes many forms and takes a lot of time too, but it can be a very rewarding experience, especially when you see a lot of the fruits of your efforts impacting your own practice or benefiting patients. So it's been a very fulfilling, very rewarding experience for me personally. And I hope that you guys get involved early. If you have an interest, I think nowadays residency programs are incorporating a lot more experiences for advocacy training and learning opportunities. And so I think it's an exciting time to be getting involved in medicine in general. So I'm happy to answer any questions that you have about child health advocacy, but I'm also happy to answer any questions that you have about general pediatrics too, since that's also my background. So feel free to ask about either of those. Thank you.
Thank you so much, Dr. Qaadir, for that incredibly informative session. We really appreciate it. And we're going to be starting with our Q&A now.
Thank you, Dr. Qaadir. My name is Hamza. I'm from New Jersey. I'm matriculating into a joint BSDO program with Seton Hall University and the Lake Erie College of Osteopathic Medicine in Pennsylvania. To start off our Q&A, one question we had was, what is your primary motivation behind pursuing child healthcare advocacy as a pediatrician?
So I think, as I mentioned, when I got sort of to this mid-career point, as a pediatrician, seeing some of the roadblocks that I was facing, some of the challenges that are more of a systemic nature that I couldn't get around as a provider, that sort of motivated me to kind of poke around and find out, who could I talk to or how could I get involved in efforts that would actually change things, either at the local level, the state level, or even the federal level that could improve things. So I think it was as a result of me getting to a point in my practice where I was seeing some of these challenges and then wondering, how could I get involved in effectuating some change? I remember also hearing about Dr. Hannah Atisha, the pediatrician who advocated a lot in Flint about the lead crisis there. And I just thought that was really cool how one pediatrician could raise awareness, get the data, talk to legislators and kind of get something done. And it sort of inspired me in a way that, you know, as a pediatrician, you see things, you have that direct connection with patients. And then, you know, if you can find the right people to collaborate with and to support your efforts, you could actually make some change. I would be remiss if I didn't mention that I have family members that have been very involved in public health and sort of grassroots community health advocacy for a long time. And so I was kind of exposed to that at a younger age. But I think in terms of my pediatric interest, that sort of naturally evolved as I got into sort of mid-career and saw some of these issues.
And thank you for the answer. Before legislation is passed, is there anything else healthcare providers can do to bridge gaps in child healthcare?
Before legislation is passed. Do you mean like apart from legislation? What else can one do to bridge a gap in healthcare? I mean, certainly if there's something at a systemic level that needs changing, you know, there's a legal approach to changing things, and there are other ways that people can collaborate together to create programs, for example, that may not involve changing laws, right? But it may just be like, let's get together and, you know, develop a program that will be beneficial for patients. So for example, there's a lot of issues with like food insecurity that we get concerned about. Food insecurity means, you know, either access to healthy foods or, you know, issues of malnutrition that we may see in kids. So some pediatricians, for example, there's one office in particular here that took it upon themselves to really focus on that issue and that gap in access to healthy foods. And they developed a program called Food for Others, in which they gave out these sort of, I guess you'd call them prescriptions for healthy foods. And they did an active screening campaign of their patients, like very actively to ask, you know, about food insecurity. And then with that information, they were giving out these prescriptions and sending them to a food bank that they had collaborated with in order to improve that access to healthy foods. And so like that was just at one local practice, for example. So there are ways you can do things even without changing the laws, sure.
All right, thank you for that answer as well. When pediatricians testify for or against a bill, how much of an impact does it usually make on the vote?
That's a great question. And I think it actually makes a significant impact. I think one thing that you will find as healthcare providers is that physicians are very highly respected voices, especially when you are talking to lawmakers and legislators. And we kind of forget that because we're in our own bubble. But physicians are very respected voices, and in particular, pediatricians are kind of like the nicest kids on the block when it comes to physicians. Often that's how we're viewed. But I think that our voices are very much taken seriously. They're very much respected. And I think that was something I didn't realize before getting involved, but both at the state level and the federal level, they do really listen and they really appreciate, and they take what you are saying with great authority and appreciation. I think the bigger challenge is not so much whether or not they take our voices into account, as it may be other political factors at stake, right? For example, what administration is in power and so on and so forth. But I do believe our voices are very important. And also to keep in mind, like when you start going to do these lobbying efforts at the state legislature, or even at the federal level at the Capitol, you're walking these halls, you see all these other groups that are there lobbying too. And so you'd be surprised, there are, the NPs have their great lobbying team, the pharmacists have their great lobbying team, all different types of groups that I hadn't even heard of, they're there. And so as physicians, it's really important to also be there.
Thank you. Here's another question we have. Why do you think mental health related cases in children are rising? And do you think it could be related to the use or the rise of social media?
Definitely, yes. There are a lot of different reasons that we are seeing this mental health crisis in children. And this has been going on, like I said, for more than a decade. But I think now with the pandemic, it is definitely escalated. Social media has definitely contributed a lot to adverse effects on children's mental health. The sort of false images that people project of these idealized perfect lives or clothes or appearances, and all of that has a tremendous negative impact on children and at a very impressionable age. I'm trying to remember the name. You guys might remind me. There was a recent Netflix documentary. I think it was called The Social Dilemma, if I'm not mistaken. I can look it up in a second, but basically it really focused it on the negative impacts of social media on children and teenagers in particular, because you're at a very formative age and you're kind of development as well. And so, yes, definitely that has had an adverse effect. And then of course with the pandemic, like I mentioned, the social isolation and the pulling away from some of the resources that kids had in schools, like counselors, normal socialization, the stressors that parents are under that are then, trickling down and affecting the kids. These are all, having a variety of negative consequences for children.
All right, thank you for that question. The next question actually comes from Clarice, and I'm going to have her ask her question.
Hi, good morning. Thank you.
This is another thing I'll mention about that.
No, you're good. I think it was just lagging.
Wait, am I lagging?
I think Dr. Qaadir has frozen.
Oh, okay. I'll just wait.
Sorry, everyone. We'll try to fix this.
Yeah, Dr. Katz will be rejoining. But really quick, in the chat box, where is everyone from? So I'm currently in Maryland. Nice. Okay, I see Maryland. Oh, NYC. Cool. New York, California. So cool, from coast to coast. And that's really early in California. Awesome, you guys are waking up so early on a Saturday morning. Yeah, a little too early. I know a couple, yeah. Minneapolis, nice. Okay, and Dr. Qaadir is back, I think.
All right, now that Dr. Qaadir's back, I think Clarice can ask her question now.
Okay. Hi. So I was wondering if pediatricians had come across or learned anything about social and emotional learning programs. It was a term that I had come across a few years ago. I was wondering if you guys are familiar with these programs and whether or not implementing them could have a really positive effect on preventing or mitigating the onset of mental health disorders.
Dr. Qaadir, you're muted.
Sorry. I haven't heard of that specific term, but can you give me a little context about it?
Yeah, so when I was learning about these programs, basically they are a certain curriculum that can be implemented in K through 12 education that teaches students all throughout how to, like, emotional management, learning about mental and emotional health, how can they interact healthily in social settings. So teaching students the skills they can have to take care of themselves and to take care of their relationships. And
nice.
I didn't know if you had heard about
that's
that.
geared toward Yeah, no, and so that's geared towards schools then, like in schools they're doing this? Got it, okay, yeah, no, definitely. I think that going forward, there needs to be more collaboration with schools and with medical providers and mental health therapists and pediatricians on this topic. And one of the things I was gonna mention, I think when I was disconnected was just to exactly your point, like there's one aspect of addressing the mental health crisis in kids, which is the treatment aspect, which I talked about, right? When they're coming to us, and then how do we address it? But then, as with every other aspect of medicine, there's always the importance of preventative care, right? So whether we do that for asthma or diabetes, we also have to do that for mental health, and particularly for our youth. Early intervention is always key and critical to long-term well-being and health. And so one of the things that I've, tried to do in my practice when, again, it takes time, but educating parents and families about things like mindfulness. And there are lots of different resources, for example, available for even smaller kids to practice certain exercises at their level that can sort of instill a calming, self-regulating practices that may be mindfulness and similar things, but there are lots of different techniques to do that. And so I do try to, educate parents and families about those things that can help them, getting out into nature, going for walks, exercise, all of these things that are naturally available for us that can really help manage and cope with anxiety and stressors, because kids are going to face a lot of difficulties, a lot of challenges, a lot of traumatic experiences that unfortunately are out of, their control. And so it's up to us as caregivers, as supporters, to be able to give them the tools to develop resilience, right? And so exactly to what you're saying, I think if schools are implementing programs where they're educating students about how to cope in mental health, in sort of emotional regulation techniques and interventions that they can do and practices from an early age, that's critical. And so I do think, like, if there are more programs like that, pediatricians would definitely want to collaborate and help partner on those for sure.
Thank you.
All right, thank you for that answer. And thank you, Clarice, for her question. Now, the next question we have is, what role do the social determinants of health play in the healthcare disparities you have witnessed in your patients?
That's an excellent question. I think the sort of short answer to that, which is often quoted in a lot of talks, is that a lot of your health outcomes and your quality of life is determined by your zip code. I think you've heard that, maybe some of you, but when we talk about social determinants of health, a lot of these things have to do with where you live, your demographic, the socioeconomic status and community that you live in, and what opportunities, what resources, and what challenges you are exposed to. If I'm thinking about my particular patient population, I think that, one of the challenges that I see a lot with the demographic of the kids that I see is that, for example, when it comes to nutrition, most of their parents are working double jobs, often single parents. A lot of these kids come home and they're on their own. And whereas in more affluent communities, the same age group of kids may have after school sports activities. They may have parents driving them around and able to engage in a lot of healthy activities or healthier foods. The kids that I see often are coming home and they're on their own. I would want to say, hey, go, get involved in this team sport. And then frequently the response that I get is, but I have no one to drive me there. I don't have any transportation there. My mom doesn't get home till 9, 10 o'clock at night, or I also have to work a job. Those are the frequent conversations that I'm having because of the financial situation that they're in, where, the opportunities for healthy lifestyle are much more limited. And so a lot of my conversations revolve around that discussion and how can we brainstorm ways to find a middle ground to make things better. There was one, for example, there was one patient who actually, it was more concerning for me outside of the nutrition part of it, was that I think her kids were very young. There was like a 5-year-old and maybe a 10-year-old. And it came to my attention through talking about nutrition and what they're eating and what's going on at home that they were alone. And there was no adult. And so then I was a little bit concerned about, child protection and safety. And so I got into this conversation with the mom, and I was like, she was a single mom and all this complicated family situation. And, and I said, like, we really have to find some solutions. And I did call CPS because I was concerned about the situation, but also to get some advice. And the nice thing about, again, some of the
Sorry, Dr. Qaadir, I think that you were cut off again.
Yeah, she's frozen.
That's okay. I think it'll take like another 30, 40 seconds. Okay, I think Dr.
Sorry, did it get disconnected again?
Yeah.
Got it. Sorry, I don't know why that's happening, but yeah, basically a lot of the social determinants of health that I see have a lot to do with the financial issues and then the limitations in their resources and helping navigate them, find some middle ground, some balance. But it's a huge disparity because if I were to go 30 miles in another direction in a different demographic, these kids have a very different experience of like their after school life, for example.
All right, thank you. This next question that's coming up is very similar. Which communities in America do you think are the most in need of child health advocacy? Oh, she froze again.
Yeah, I mean, that's a really good question. It's hard for me to actually pinpoint one particular community because I think when it comes to children and depending on the issues, it really is kind of across the board. But certainly, when you think about mental health, I mean, that actually is kind of across the board. But certainly, I would say that communities that are often underrepresented, you will see a need that we need to kind of speak up for more and that have more unique challenges because of the disparity. We'll see in communities of color, right? So obviously with a lot of children of color in the Black community and just the impact of what has been ongoing for so long in terms of racial discrimination and disparities, those children are facing unique challenges that their counterparts are not facing. And interestingly, just as a side note, as medical providers, it's becoming more and more apparent to us how there are biases in our own care for a lot of children or families, patients of color. And there was a study done not too long ago in Virginia among medical students assessing what they determined to be pain tolerance for patients. And there was a difference in what they thought was pain tolerance levels for Black patients and white patients, which is concerning. It's something that's sort of an implicit bias that we're not even aware of. And so for children, definitely, I think, Black children are facing certain levels of trauma that are significantly greater and more concerning and need attention. Also, in terms of a lot of these immigrant children, like I mentioned, especially these migrant kids that are coming, they have seen and faced so much trauma, and yet they don't have access to any healthcare, right, coverage. Those are particular communities and rural communities. There are lots and lots of kids in rural communities that don't have easy access to medical providers and medical care. And so I would say that, those are a few of the communities that we need to do a better job of in addressing their particular needs. But with children, it's almost across the board in terms of advocacy. Every child benefits when we work on policies that help to protect them.
All right. Thank you for this answer. Another question we have is, what would you say is the most pressing healthcare need that children are lacking in such communities, and where access is limited?
Can you repeat that one more time?
So what would you say is the most pressing healthcare need that children are lacking in these communities that we've talked about? And where is this access limited?
So again, it's hard to pinpoint one particular thing. I would say for immigrant children, it's lack of health insurance because that limits so much of what we can do and how we can care for them. I also think that for a lot of kids in lower income communities, access to healthy nutrition is an important issue because, as you guys may know, when you live in certain lower income communities, there are what are known as food deserts where you don't have access to healthy grocery stores or Trader Joe's or things like that. And, the only thing affordable are usually processed foods or unhealthy items. And so, for example, in Virginia, we recently worked on some legislation for a healthy produce bill, which would basically give Medicaid recipients these prescription produce vouchers that would allow them to get free healthy fruits and vegetables. So, being able to get healthy foods out to these communities, I think is really critical because, again, a lot of, the health implications that we see as a result of lack of access to those nutritional needs is apparent. And we are seeing increasing numbers of obesity at a national level, and definitely the, poor communities, children of color, they're more adversely impacted with that. And certainly with COVID, you guys may have seen like children from immigrant families and Black children and their families were disproportionately impacted from the pandemic. And so, those are all issues that are relevant. And climate change is another area that I didn't touch on. I mean, it's a whole nother topic. And we actually have one of our pediatrician advocates in our group that is basically solely focused primarily on climate change issues and how it relates to kids. And she's amazing. If anybody has an interest, I can always connect you. But, interesting, a lot of these things that I was mentioning that are determined by your zip code, it also is in line with what is happening with the effects of climate change. There are kids in these poor communities that were redlined, for example, that when you look at the heat index in the summer times in those areas compared to more affluent areas where there are more trees, where there's more landscape, where there's more shade, where there's more greenery, there's a significant difference even in the temperature, and when you think of these heat waves and heat strokes and things like that. So all of that, makes a difference. I'm not sure if I answered that question because it was a two-part question, but.
I think you answered it correctly. Right. Thank you for that question. Answer. And we have another question for you. Why is it so difficult for some of these mental health programs in Virginia to come to fruition when it seems to be of such a big concern?
Funding. I think everyone would agree that it's an important program, but it costs money, right? It costs millions of dollars. And there's always a tug of war in terms of where money is spent, where it's allocated in the budget. And like I mentioned before, I think that specifically during the pandemic, while everybody agreed, yeah, it's good to have mental health programs for kids, during the pandemic, no lawmaker initially would have thought intuitively that this program would be a priority issue because it just wouldn't sort of click. There's like emergency this and emergency that and food and all this other stuff that they're dealing with. So it was our job to kind of connect the dots for them and to say, no, look, this pandemic is directly impacting their mental health and you're going to have an even greater crisis on your hands if we don't keep this program funded now. So I think a lot of it boils down to money.
Thank you, Dr. Qaadir. I'd like to request Zaid to ask closing questions.
Thank you, Hamza. My name is Zaid and I'm a rising undergraduate behavioral sciences major from California. To start off, we'd like to say that we are very inspired by your career and we're curious about why you are pursuing an MPH and how it could further advance your goals towards child advocacy?
It's funny you asked that because I was actually hesitant to put that in there. I was like, someone's going to ask me why I'm doing that. So it's interesting that you guys asked me to give this talk at this a juncture, actually, and I really enjoyed doing it because I am what would be considered a mid-career pediatrician. I've been in practice for 10 years. And I think this past year, I definitely felt with the pandemic and with everything else, it was sort of this transition period for me also professionally and thinking about what I wanted to do. And I got involved in child health advocacy a few years ago, and it really was something that I fell in love with. I really enjoyed the other pediatricians that I got to, that I get to work with and collaborate with. It was very inspiring to me. And like I mentioned, part of the reason that I'm actually transitioning out of private practice into a hospital setting, which is a more academic practice, is because it will give me more opportunities to collaborate at a kind of system-wide level with other providers and other faculty on advocacy related projects, say with residents, say with medical students, and we can collaborate together. For me, I found a lot of those openings in collaboration rather than trying to do things on my own. And in private practice, you're kind of on your own. And so I think because of my interest in advocacy, I also thought, it would be interesting at some point in my career path if I might like to do a little bit more policy work in my career itself. And so I could envision, a point in my life later on down the road where maybe I would cut back clinically. And that's another nice thing about, different aspects of being a pediatrician is there's lots of flexibility in how you set up your schedule depending on where you work. But there are places where people may, for example, if they work in an academic center, they may work 1 or 2 days clinically, and then they spend a few days working on some advocacy related projects. And so I might be interested in doing something like that in the future, or maybe later on in my life, working for a policy, a child health policy institute or something more policy driven, and maybe cut back on my clinical work. I'm not sure exactly how I want to do it in the long term, but it's definitely an interest that I have. And so this past year, I kind of thought to myself, it might be nice to pursue an MPH to get more of a background in health policy and an understanding of the history, the historical data and trends, and to kind of educate myself more. And I think it's always fun and valuable if you have the opportunity and the time and the resources to continue to educate yourself, and sort of continuing education advice that we give to everyone at different stages of the career. And so, yeah, I think that's sort of how it evolved into me being interested in pursuing an MPH, and maybe that will open up some doors for me long-term future when I may want to do a little bit more policy work and maybe a little less clinical work.
Thank you. Earlier in this session, you mentioned that the pandemic has had a negative effect on children's mental health. Have you observed any other sort of negative or positive effects on child's health as a result of this pandemic?
Yeah, I think the other big thing we've noticed is the issue with food insecurity. And so a lot of, especially, in the demographic that I care for, a lot of these immigrant families did not have access to the same federal resources that other families did, particularly if they were undocumented. Even though a lot of these families are still tax paying, because of their documentation status, they did not necessarily receive these stimulus checks and support that other families did. And so they really, really suffered and are suffering financially. And so food and access to food became a huge issue during the pandemic. And one of the other things we did actually during the pandemic, like I mentioned, how we pooled all our resources together for health clinics that would see undocumented kids. Another thing we did was pool together regionally the different food distribution sites across the state. And there's one here in Northern Virginia, an organization called MCCP, Medical Care for Children's Partnership, that is geared towards helping underserved and uninsured children and families, that they set up a food distribution site every month since the pandemic began at a local library in their parking lot. And so for the past year, every month, these pediatricians and other non-medical volunteers have gotten together to distribute food for these largely immigrant families in that particular area of Northern Virginia in Falls Church. And, I've gone there once or twice, and the line is very, it's a very, what's the word I want to use? It's a very moving and heavy and kind of difficult thing to see, because it's this really, really long line of hundreds of women and children basically standing for 2-3 hours waiting just for basic staples, for basic food. And they give out a good couple hundred meals each time that they do that. And they've been doing that since the beginning of the pandemic. And so we, definitely we have seen the impact of the financial strain and lack of access to basic groceries and food for a lot of these kids as a result of the pandemic as well.
Nice. Thank you so much for that answer. Another question we had was, there are many doctors who believe that to truly heal a patient, the physical health, mental health, and all spiritual health all must be addressed together. How do pediatricians help with the spiritual health of younger children who might not have had as developed sense of spirituality as older patients?
So I think that, that's a kind of a complicated question, but definitely it's something that I value as well. And I try to incorporate that into my clinical practice. I think that, in terms of, as we mentioned earlier, it's important to be able to have conversations with families and educate them about different methods of, mindfulness and being present and ways to manage stress and things like that. And when it comes to spiritual discussions, I mean, those can get a little bit more personal, right? And I think it depends on your relationship with the family. So there are, once you develop those relationships and get to know your patients and families, then that lends itself to opportunities to have certain discussions. And so certainly I have had families from different faith traditions, not just my own faith tradition, but other faith traditions too, where, when there is this understanding of a certain sense of perspective on life and, a spiritual perspective to life, we definitely have those conversations and we talk about it together, because it is something that I value. And I think it's a holistic approach to understanding life and how you manage a lot of difficulties in life. And again, like as a pediatrician, I might see them for some physical ailment, but oftentimes the parents will sit in my office and we'll talk about other things that they're dealing with as a family. Families are going through a lot of different traumatic experiences of different natures for a variety of reasons. And those things do come up, especially after you've developed a certain relationship with them. And, they're very emotional conversations at times. And so we do, I'm very open to talking about that and meeting them at their level. So I definitely value that. And I do incorporate that when those opportunities arise.
Speaking of building relationships with families, some parents may pressure their children to not seeking or taking the help that they need, especially in terms of mental health, or may be seen as a little taboo. How can this issue be managed by the pediatrician?
That's a really good question. And I think it's an important area to address for us as pediatricians as well. When I have conversations with family members, sometimes we do see that. I do see that, right? The parents, will be a little bit reluctant to have a certain diagnosis or to seek out counseling or, definitely like psychiatry referrals or medication and things like that, right? And so again, it's something where you have to meet them where they're at. But, I had one parent, I remember both the kids were suffering from some pretty serious issues. One had a lot of anxiety. She was a teenager. The parents were immigrants and the dad had grown up in pretty rough conditions and, refugee camp and so on. And he was basically like, in the beginning of, when I first started seeing them for these particular issues, he was kind of like, I don't really get it. Like, we had it a lot worse and you just dealt with it. Right now, everybody has to give labels to things, but we just dealt with it, But then over the course of, a series of visits with them and all, his perspective really evolved. And I think, what I try to do is basically destigmatize, first of all, the issues. And I think it's very important to remember to remind families that, mental health conditions are just as real as your physical health conditions, your asthma and your diabetes and your hypertension. And, when, I talk to parents and families, I also try to be realistic with them about some of the challenges of seeking out help because, for example, sometimes it's hard to get an appointment with a therapist, and then you get an appointment with a therapist and then it's kind of like you didn't have a good experience. And so then you just give up on it. So I always try to reason with them about the need to kind of give things time, try a few different providers if one doesn't match well with you, and that there can be a lot of benefit to it. I also explain to them that, like, when we're dealing with mental health issues, we're not here to just throw medications on patients, right? That's usually a second line intervention at times when it's needed. But the first line is to kind of get help through, for example, CBT, cognitive behavioral therapy, ways that can help you kind of think about things differently and reframe the way that you're looking at things. And I honestly also give personal sort of examples. And I say, look, I think that everybody goes through stressors in life. They go through traumatic experiences in life. And we all need help outside of our own immediate family. Like you're all in this boat together, right? But you're all kind of paddling the boat and kind of dealing with the tides and trying to navigate it yourself inside. But often you need help from the outside, and that outside perspective can give you a different objective approach to see things in a way that you may not see. And also, because a lot of times families just try to navigate things internally, I remind them that you only have so much bandwidth, as a mom, as a dad, you only have so much that you can give before you're depleted, right? And you need to take care of yourself, and your child needs help, right? So kind of emphasizing why there's this importance for outside professional help and how that can be beneficial. And then I also remind them that, look, everybody is going to deal with something difficult, something stressful and traumatic at some point in their life. And we all need those lifelines, and we all need those sources of support. And I would say I myself and my family members have sought out those supports when we need them. So I'll give that example too, right? Like I'll normalize it for them. And so I try different ways to kind of connect with them, but you also have to understand that it will take time for a lot of families. And so, sometimes it's a gradual discussion, and maybe they're not ready at a certain point, but then over time they see the need. And then when they see the benefits, then, it's definitely something that they can understand the value of.
Thank you so much. And for our last question of the session, what are your thoughts on pursuing a universal healthcare system in the US? And do you believe it's possible to implement such a system or a similar system?
I don't know that I have a very strong opinion on that, to be quite honest. I think certainly there is a need for broader healthcare access. I think, Medicaid expansion and, those are all very, very important and critical needs. I don't really have a strong opinion on universal healthcare personally. I know the physician community in general has different views on that. But I'm not somebody that's looking at my, billables and reimbursed, rates of service and things like that, to be honest. So for me, I think, if you were to ask me personally, I think, yes, the broader access that one has for healthcare coverage for everybody is essential. And I think when you don't have access to healthcare and you see how debilitating that is, you understand why everybody says healthcare is a right and not a privilege. So I don't have strong feelings on that, but I definitely think that the more that we can expand coverage, the more, the better that we'll be as a society, for sure.
Thank you so much, Dr. Qaadir. Those are all of our questions for today. And we have also linked Dr. Qaadir's op-eds in the chat box if you'd like to learn more.
Great, thank you so much. And it was really fun to do this. And if you guys, have any other questions or want to reach out to me, I'm happy to be in touch. I guess I can give the moderators my contact information if that's the best way.
Thank you so much, Dr. Qaadir. We truly appreciate you taking the time to answer our questions. I'd love everyone to please give a warm thank you to Dr. Qaadir in the chat box for this incredibly informative session.
Thank you. Thank you for inviting me. And yeah, I have lots of colleagues and friends that would be probably interested to talk to you guys on their areas of expertise too. So definitely thank you for what you're doing and bridging this connection with students and with physicians. It's really wonderful.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live. Again, you'll need a 70% or higher to pass and receive certification. And the link to the quiz is going to be sent in the Zoom chat box. Many of our students have expressed interest in pursuing a leadership position in teleshadowing. We do have positions open and our leadership page, as we truly and strongly believe in having more students on our team for our Campus Ambassador program. Next, we're going to move on to our future session dates. Due to the overwhelming response from students who want to learn more about internal and family medicine, we're hosting more internal medicine and family medicine sessions that will cover most medical conditions to give you all the most experience. We will also have a lot of other specialties in between. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session, which is next Saturday on May 22nd at 10 a.m. Eastern Standard Time with our physician mentor specialized in internal medicine. Thank you so much, everyone, for attending today's session, and we hope to see you next week and in upcoming sessions as well. This concludes this week's shadowing session.